But now we'll just go ahead and transition right over into, like we said, we're going quickly, our next panel on medical dental integration. So I'll hand it over to Sandy to kick us off.
Thank you, Brianna, and thank you everybody on the advocacy panel. Our next group of panelists will be moderated by Dr. Bruce Wilcox. And we are so pleased to have Dr. Wilcox. He graduated from the University of British Columbia School of Dentistry in 1994. And throughout his career, he's had this interest in how do we solve these difficult access to care issues and problems. His very first dental practice was taking portable dental equipment into long-term care homes and providing dental services on site. So you can see he has a long history of providing care where people are. In 2004, he entered the community health center world and worked in Washington State. He fell in love with organized community health, and he led a clinic at the Yakima Valley Farm Workers Clinic and was also the dental director at the Columbia Valley Community Health Center in Washington. About 4 years ago, we were so excited that Dr. Wilcox came to Arizona, and he is now the dental director at North Country Healthcare, and that is our safety net clinic in Northern Arizona with 12 sites. And thank you, Dr. Wilcox, so much for moderating our panel on medical dental integration.
Thanks so much, Sandy. Appreciate that great introduction. Medical dental integration is a practice that can really improve the health of our communities. I'm gonna read through a quote from the NEIH NIDCR report from 2021, which was entitled Oral Health in America. It acknowledged medical dental integration as a crucial strategy for addressing the persistent disparities in oral health outcomes. There are many barriers to integration due to a long history of separation in almost every facet of practice. However, finding ways to overcome the resistance and provide comprehensive collaborative care is possible. I agree with everything in that statement. I think there's lots of different ways that we can engage around education rather than just treatment to improve lives. It's quite stunning to me coming here from Washington State, where the ABCD program really attempts to get into schools and other locations to get education to kids, has changed the rate of decay hugely in that state. And I think it's just all the more focused when we have the medical visits that happen anyway, just have oral health as a part. I want to introduce our panelists. Katharine Martinez is a registered dental hygienist with a master's in public health. She earned her master's degree from New Mexico State University and her undergraduate degree in dental hygiene from the University of New Mexico. She's widely recognized as a role model and as an oral health educator in the hospital setting. She's created a role that incorporates an oral health professional to be part of the multidisciplinary team that has led to improving patient outcomes and decreasing hospital-acquired infections. Dr. Michelle Panico has been a registered dental hygienist since 2000. She has a Doctor of Health Sciences with an emphasis in global health and a project management professional certification. She has 9 years of project management experience, taking new concepts and strategies from planning to implementation within hospital systems, managed care health plans, clinical dental practices, and dental education. Dr. Panico has been a member of the American and Arizona Dental Hygienists Association since 2000, and she's been an active contributor to state advocacy and legislation for oral health in Arizona. Cherith Flowerday is a professional project manager for nonprofits with 9 years of experience in oral health and 18 years in public health and grants. She has worked on two of Colorado's most well-known medical dental integration projects, the Colorado Medical and Dental Integration Project and the Rocky Mountain Network for Oral Health. In these oral health roles, she's served as a grant officer, project manager, practice coach, and subject matter expert. And she's worked with public health clinics across Colorado and now in a 4-state region. And I'm very proud to have been able to work with her on that project with our health center. Dr. Eve B. Hoover is an associate professor of and PA at Midwestern University PA program. Through 15 years of rural health medicine practice, she developed a passion for preventative medicine and education. Eve was selected as Arizona's oral health champion in 2021 as part of the 100 Million Mouths campaign through the Center of Integration for of Primary Care and Oral Health. Well, appreciate everyone joining on, and we'll dive into some of our questions. I'd like each of the panelists to tell us a little bit about, just from a 50,000-foot view, what are the key integration strategies you've used in your role. And we'll start with Katharine and just go around the order that's presented on the screens from there.
Perfect. Thanks, Dr. Wilcox, for that great opening and introduction. And like you said, education is really key. And in my role as an oral health education specialist at Phoenix Children's Hospital, that is exactly what I do. I educate to all of the patients and families on proper oral care. I educate to the nurses, the residents, the fellows, the hospitalists in the hospital on how to do proper oral hygiene care in order to optimize better patient outcomes, specifically decreasing hospital-acquired infections within the populations. We're decreasing non-ventilator hospital-acquired pneumonia, ventilator-acquired pneumonia, and as well as mucosal barrier injury, central line associated bloodstream infections. All of that is linked to oral bacteria. So what we do is we go into that multidisciplinary team. We do rounds with the quality improvement specialist, the infection control, and all of these providers in order to help educate on better oral health assessments, better oral hygiene education, and to kind of give a better, well-rounded approach as to how do we treatment plan for that patient who maybe is a little bit more medically complex and at a greater risk of developing infections. So we go around and really try to work with that education, taking the clinical aspect out of clinical dental hygiene and really emphasizing the education and the oral assessments.
So there are 3 programs that I've had the opportunity to contribute to developing and overseeing when I served in the role as manager of the Community Oral Health Department with Dignity Health at Chandler Regional Medical Center and at Mercy Gilbert Medical Center. First program is there are 2 dental clinics. The dental clinics are affiliated practice or direct access to care provider preventive dental clinics that are licensed as outpatient treatment centers and are owned by the 2 hospitals. The dental clinics serve as safety net clinics for children up to age 21 who are from low-income homes with no dental insurance. And services that are provided at both clinics include oral assessments, radiographs, dental prophylaxis, periodontal therapy, fluoride treatments, including fluoride varnish and silver diaming. Also, the team there provides interim therapeutic restorations and family oral health education with a promotora and care coordination for services that are outside the scope of the affiliated practice dental hygienist. The medical dental integration model here is that we have some integration of dental within a healthcare system in an outpatient setting. The second program is the First Sees First program. It's a portable program that consists of dental hygienists and promotoras that provide oral screenings, fluoride varnish, and care coordination services out in the community at pediatric medical offices and child care facilities. Prior to COVID, we had additional partners that included OBGYN offices and WIC centers. The program continues to serve these populations from teledentistry services and also partnerships with nonprofit organizations that serve groups of expectant moms. So the target population here for this program is children up to age 6 and expectant moms. And the medical dental integration model here with the First These First program is that we have some dental integration within primary care offices and settings. The third program and last program that I'll mention is our ICU oral care program. The ICU oral care program integrates dental hygienists in the medical and trauma ICU center at Chandler Regional Medical Center, and it provides bedside oral health assessments, and we implement an oral care protocol after the assessment is completed. So the aim of this program is to reduce the ventilator-associated pneumonia, reduce costs, and reduce mortality. So the target population for this program is adults with advanced airways, like a tracheostomy or intubation. So the medical dental integration models here is dental integration within an inpatient hospital setting. I'll pass the baton to Cherith.
All right, thank you. Yeah, so our question about like key integration strategies in my role. So I've been essentially the project manager on 2 very large projects. We've worked with about 50 clinics over the last 9 years in medical dental integration. Most of the clinics that I've worked with have been federally qualified health centers, but there have been a few private practices and a few nonprofits that were not federally qualified along the way. So it was interesting to see the variety there. Having done this with a lot of clinics, we've always been looking at like what makes it successful and what makes this not successful. So I thought I'd just highlight a few characteristics that pretty consistently lead to success, and if they're not there, don't lead to success. So first of all, having a target population that needs the services that are being provided. Oh, I forgot to say, in our medical dental integration work, it's been a variety of models. It could be medical providers providing caries risk assessment, fluoride varnish, and education. It could be medical providers, and I'm talking about outpatient clinics. It could be medical providers delegating some of that work to their support staff, could be MAs or nurses, or it could be dental hygienists that are integrated into the medical practice and coordinating with the medical team, and the hygienists are the one doing those services. So there's a few different models, or there's a mixture of models. So anyhow, having the right target population basically means people who don't already have insurance, so they actually need the services you're providing. Buy-in from leadership and providers and staff. Time to work on this. If there's not time to work on it, it's likely to have a lot of challenges because it's not easy to do. The ability for teams to create and implement new workflows, because a lot of change is involved in integration. Also, the adaptability of electronic records, whether they're medical or dental, can be quite a hurdle to overcome. Scope of practice is different in every state, so this can be something that has to be worked on. Reimbursement, and that's obviously different if you're a FQHC or not. And then depending on the model chosen, there may be a need for startup funds for salary or equipment, for example, if they were to hire a hygienist. So anyhow, those are some of the main things we've felt to be important when doing medical dental integration, and those are the strategies we focus on.
All right, thank you. Hello, everyone. Thank you so much for the opportunity to be here. Speaking about the 100 Million Mouths campaign and my role in that. So the 100 Million Mouths campaign is an organization that was started by the center, the integration with primary care and oral health, which is what our goal is here, but it's through Harvard. And so what their focus is selecting one oral health champion from each state. They're up to about 22, I think now, 22 different states, and the goal is 50 over the course of 10 years. And this initiative started just a few years ago. So basically, the foundation is speaking to a lot of the things that we've all been discussing, that I'm really inspired by the dialogue that's happening today. But it's things like prevention is key, the silo is the barrier, and the connection between oral health and systemic health, and reaching the learner very early on. So basically what we do as oral health champions is we are really encouraged to connect, communicate, and collaborate with 3 different educational programs, primary care educational programs across our state of Arizona. So I've been able in the last year and a half to connect with 7 different programs. So multiple different PA programs within our state, nurse practitioner programs, DO programs, and a family medicine residency. And what we do is we start off with an assessment, and basically that looks at the depth and the breadth of how oral health is already taught in the existing curriculum. And then what it allows is it provides resources, free resources, and ways in which very efficiently and effectively programs can begin expanding their oral health coverage within primary care. And so I've loved working with all these different programs and learning from so many people. It's been really an inspirational a role for me that I've greatly enjoyed.
Thank you all for those summaries. I think probably the most interesting piece that started to come out there was, what are the factors that make for success, and more free form this cycle, but let's have some discussion around, what are the factors for success, and tie that to what the outcome is that you see from, providing that factor.
So some of the key important factors for my role specifically is getting some of the internal stakeholders who, like the chief nursing officer, some of the medical directors of the hospital, all on the same page as to how we can implement oral care into the hospital setting. So they've been really key components of making sure that this position actually sticks and making it a long-term position, because originally it was only a grant funded position. And so once 3 years was up for that grant fund, it was determining how do we continue to fund an oral health educator in the hospital setting. And because of the outcome that we had with, improving the patient outcomes, decreasing the patient's readmission rates, improving their comfortability of the nurses and the medical providers, and doing oral assessments and individualizing that treatment care, and decreasing hospital-acquired infections, it kind of was a no-brainer for the hospital to say, we're going to continue to fund this position and this role. So now it's 50% grant funded and 50% hospital funded, with the hopes down the road that it's going to become a full 100% funded position. So having those internal key stakeholders has been key for this position.
Great. Other comments? Go ahead, Michelle.
Okay, so for our 3 programs that I was mentioning earlier, I would say some successes and outcomes around the dental clinics. One of the large successes there is the use of the affiliated practice model. The affiliated practice dental hygiene model allows dental hygienists to perform procedures that are permissible in the Dental State Practice Act in non-traditional settings without a dentist's presence or examination or diagnosis and treatment plan prior. So the outcome or success of using this model is how service delivery model looks different, and it really serves as an additional entry point into the oral health care system for patients. It's another tool in our toolbox really to address health equity. Some of our program outcomes from utilizing this model, over 15 years, we've been measuring some patient oral health indicators, such as no new decay upon their second visit, plaque scores, and gingival health. And we've seen a demonstration of improvement in individual patient oral health, but also at a larger population health and community impact has been very positive also with the education and oral health indicator improvements. With the First Sees First program, I think one of the successes there is the use of, again, another opportunity in our Arizona Dental Practice Act that permits public health dental hygienists in Arizona working or volunteering for a public health or school authority to provide sealants, fluorides, screenings, and assessments prior to the exam by a dentist. And that program has really utilized that public health type of dental hygienist that's permissible in that Arizona Dental State Practice Act, and has had some great outcomes, and not only providing fluoride varnish screens and screenings, but also care coordination to establish a dental home. So we've seen increase in patients in the community that have actually been plugged in to a dental home and have an established dental health home. The third program was the ICU oral care. So I think one of the successes in this model is the true medical dental integration partnership and collaboration that we've gained with the nurses. It's been really, really favorable and amazing to see how the nurses have really welcomed us into their home or into their space. Notable outcomes after the program initiated as a grant-funded research project, and there were some notable outcomes from that research project. So at the end of that project, the nursing staff and leadership asked the program to continue. So I consider that a successful outcome. And our nurse champion, Allie Conway, and the dental hygienist then moved forward to train nurses on the bedside oral assessment tool and the oral care protocol. And then we also implemented a dental hygiene student rotation so that the next generation of dental hygiene providers can gain some experience in this type of care delivery model. So one of the underpinnings of this model is also built within our Arizona Dental Practice Act, and it permits dental hygienists to provide services under general supervision of a physician in an inpatient hospital setting. So the success really has come, and the outcomes have come from that base that was laid with the state statute.
That's great. Cherith, maybe you could talk about some of the broader outcomes that you've seen across those two enormous projects that you've been involved with.
Sure, yeah. So the first project is called the Colorado Medical Dental Integration Project. It was only in Colorado. We did work with about 27 clinics over a period of 10 plus years. Some highlights would be increasing access to care. So there were over 88,000 visits in a 5-year period of that. The period where the most concentrated work was done. Those 88,000 visits were visits where a dental hygienist was in a medical clinic. A patient came in to see a physician, and at some point during their visit, while they were in the medical room, a hygienist taps on the door, says, "Can I come in and spend 5 minutes with you?" And none of these patients were expecting to have anyone look in their mouth that day, talk to them about their teeth or anything. So just the fact alone that there were 88,000 visits like that is huge, because those are people who were not seeking out dental care particularly, but all of them left with the opportunity to get connected to more care. And most of them at least had a screening and fluoride varnish before they left. So I think that alone is a success. If we want to get a little more into the official evaluation of things, they did try to compare, well, they did a comparison of untreated dental caries in the established versus new patient visits. It's really difficult to standardize dental decay, like the rating of dental decay. We did do calibration of all the hygienists that were involved in an attempt to get there to be standard rating of that. And basically there was variability in the reduction of decay. Some clinics did have significant reduction and others didn't. And I would go back to the fact that it really depends on those characteristics I mentioned a few minutes ago and how many of those are at play as to whether or not there's success. That's probably a little more my opinion than official, but I've seen it happen enough that clinics that have a lot of those characteristics functioning well tend to have success, and clinics that struggle with more of those characteristics tend to have less success. So, and you didn't say this just now, Dr. Wilcox, but it was in our question originally. It was like, what's the most important factor you think that leads to success? And that is a hard question. I never like to be asked that question. If I absolutely had to say so, I'd probably have to narrow it down to leadership, because from leadership springs everything else. Then for Romano project, that's the one that's regional. I just want to quickly say that we track a lot of data on this project. This project is still happening right now, so it's not completed. But a lot of it is process measures, not necessarily outcome measures, which there's various reasons for that. The thing I think that's most worth mentioning is fluoride varnish application, because we know that that is evidence-based. And we also know that evidence shows that if a child has 4 fluoride varnish by age 3, there's a significant decrease in decay. So even though this is a benchmark that the clinics are still working on right now, at this point, I can say that over half the clinics have had over 50% of their children reach 3 fluoride varnish by age 3. So that that's good at this point, and we hope to see in the next few months that that number rises, and because we know that that will impact decay. Thank you.
So one of the things that I've seen, that knock on the door is an important step, and I see that my most gregarious hygienists do better. They see more kids than people that are more shy or reserved. And one of the key things in transitioning to better knowledge is having the expectation that that oral health piece of a well-child visit happens whether the hygienist is there or not. So the expectation being that the doctor's going to do it, but oh great, the hygienist is here, and so they can do it for me and I can step off to other things. That's been a real big piece of transition. We see that gradually developing more and more, particularly with our pediatric providers. But does anybody else run into that same sort of experience? No's okay.
I might say something there. Arizona, so we're working with 8 clinics in Arizona right now, and Arizona has really taken on the dental hygiene model of integration in our project. I think all the clinics are doing the dental hygiene model, whereas we have other states that are not so much, and they're doing great at it. And I know that a lot of providers really love to have that hygienist that can pop in and do the work for them. Although I will say that there are times when there's only one hygienist and there's many more patients than the hygienist can serve. So I think in clinics that size, it works really nicely to meet more patient needs if, when the hygienist isn't available, the medical providers and or their teams can fill in those gaps.
I absolutely agree with that. And I think that has been one of the big things I've been most proud of through the 100 Million Mouse campaign, is the ability to teach our health education students, in nurse practitioner students, medical students, PA students, about the basics of fluoride varnish, to be able to incorporate that into workshops within our programs, something that previously wasn't even touched on or taught, because of course, out in practice, we need to know how to do this, but also it's not the technique that's difficult, but it's understanding why behind it, why it is so important. And so I just like to speak about that. Kind of goes with why I believe that we've had success with my involvement with the 100 Million Mouse campaign. And that's been because of the people I've had the honor to work with, because of these dedicated clinicians, these dedicated educators who are so steadfastly committed to recognizing the importance of the integration of oral health within primary care. And they've been very open to what can we do? How can we do it? And the other thing that's allowed for is really recognizing the importance of interprofessional practice and interprofessional education for our students. the recognition that we are stronger together than we are apart, and that this is a big job to do. So we'll be most effective doing it together. Also, somebody spoke previously about sustainability, the importance of not having it this year and then ending, but keeping it going and keeping improving. And so with some of the programs I've had the opportunity to work with, it's not just been one oral health champion within their program, but there's been up to 6 faculty members that have been really interested and motivated so that this will be sustainable, will continue. One other thing I want to touch on is what I believe has allowed this to be successful is the 100 Million Mouths campaign have a very strong focus on teaching oral health with an equity lens. And so many programs are looking toward how can we very effectively and relevantly teach about the social determinants of health, teach about, meaningful aspects of stories related to allowing students to recognize that they can make a difference and how to do so, teaching about oral health as it relates to social determinants of health and health equity has been a really powerful addition to programs that really want to improve their teaching of diversity, equity, and inclusion. So some outcomes, some examples of things, the fluoride varnish workshops, which now are popping up, and our ability to help fund that has been wonderful. Manuscripts, national presentations, which have occurred. But the last thing I'll say is we have started a newsletter, which goes out every single month and is focused on high-risk patient populations. And so that's an interprofessional newsletter that we got grant funding for and use a graphic designer. And so we've had a lot of feedback on that. And that goes to 70 different primary care educators, and it spans beyond that. So hopefully there's a ripple effect there.
So as we look forward to the future, what are the things that are going to be challenges for us in expanding? One of the things that we ran into in our health center was that the OB providers interpreted the Arizona law as not allowing medical assistants to apply fluoride. So there's things like that we run into. And I know that other health centers in Arizona have a completely different interpretation. So there's opportunity for clarity in the law and things like that. What do people see as the most dreadful or biggest hill that we've got to climb to get more of this happening?
Well, I think for me in my setting, it's definitely the medical billing is going to be the huge barrier for us. If I can go in and do preventative care, education, varnish, whatever, how do I bill out for that to be included and to have that position being funded going forward? Where right now we have speech therapy, we have PT, OT, all of those who can be billed out by the hospital. That's where they get their paycheck, but how are they billing out for their services? They're included in that medical kind of multidisciplinary team. So how do we get the oral care and oral health specialist part of that multidisciplinary team where they can bring in some money for that hospital so they can secure a position and also help preventative measures going forward in the future? And really, we need to start looking at hygienists as not just a clinical component, but really as primary preventative experts. We going in and educating not only the multidisciplinary team, but all around us who we're educating in order to help improve these patient outcomes is going to be key. And a challenge is constantly that re-education to everyone coming in. And we also need to expand that education to not only medical schools, but also into the dental schools and into the dental hygiene schools. Because when we're looking on the flip side, a lot of these dental hygienists don't understand these medical complex patients, and they don't understand that systemic link to that extent that they need to in order to be speaking on that level. Those are some of the challenges that I think going forward are some things that we can kind of advocate for.
Regarding some,
go ahead.
Oh, go ahead. I was just going to agree with Katharine about that. I think that's something that it's been a tough nut for me to crack for years as I've been working in this arena. It's the reimbursement pieces. We do have avenues for that, but I don't know that they're necessarily happening consistently or comprehensively. Like, for example, as Eve mentioned, they're providing, the medical providers are providing the screening and the fluoride varnish. And there is a way by which Access does reimburse certain provider types. It's the physician, physician assistant, and nurse practitioner that within Access policy can be reimbursed for those services. Now, whether medical assistant can, within their scope of practice, can apply fluoride varnish or not, I'm not sure. I don't know much about the medical assistant scope of practice, but I don't know that they'd be able to obtain reimbursement for it because they're not one of the recognized providers that Access has determined to be reimbursable for that procedure. So also with the integration of dental hygienists into the hospital in the way that Katharine is and in the way that our ICU program is, their hygienists can practice under a physician in an inpatient setting. And one of the reasons for passing that legislation into effect in Arizona was to hopefully create some type of reimbursement process by which we could utilize a medical procedure code or medical billing code for that care and for those services. But I also have run into those same roadblocks. This is a little challenging. We'll eventually crack that nut, Katharine. We just got to keep on keeping on. There's got to be a way, right? I think that the Arizona Medicaid system, the third billing mechanism that I wanted to address was the Arizona Medicaid system does recognize affiliated practice dental hygiene providers. So that's a way for some potential reimbursement through Access. Affiliated practice dental hygienists have been recognized as a provider type, so they can be reimbursed directly. However, I'm not necessarily confident that Arizona Medicaid plans are consistently contracting and credentialing affiliated practice dental hygienists for reimbursement and submission of claims. It's happening, but I think it just depends on what representative you get on the phone. Do they understand this provider type ID number 54 as you are trying to get onboarded with that Access health plan? And also that challenge, way to overcome that challenge, I think really we need to be probably educating the leaders of the health plans, right, about the benefits of them contracting with these types of different provider types, like affiliated practice hygienists or different medical provider types. I think it's in their policy, it's just not necessarily happening in practice, but helping them understand the benefits to them as a health plan is huge. I think sometimes they don't recognize that. It really helps the plans accomplish their measures in closing gaps in care. They have different measures and standards that they have to meet and that they're held accountable to from the state level. So, and also the CMS level, like their annual dental visit or the PDENT measure, these kinds of measures. And having this type of provider type out in the community doing this work, it's happening. It's just that the health plans aren't capturing it. So it's really unfortunate. We need to help the health plan understand what the benefit for them is also. Another challenge that I see, and again, a little bit with the billing side of things, is the care coordination. Care coordination really seems to be something that's coming up with this medical dental integration space. We really want to make sure that we're providing those services, and sometimes that requires different type of providers that are providing those services. May not be the dental hygienist, it may not be the medical provider, it might be someone at the front desk that's helping with this care coordination. So we really want to collaborate with Access, probably for administrative policy changes. We heard Will Humble talk about earlier on changing some of their administrative policy around reimbursement for those care coordination services. And the last I'll speak on is teledentistry. I think we really probably should have our eye on, or at least make a concerted effort to protect the practice of and payment of the teledentistry services. That this was expanded during COVID-19 pandemic, and we really want to make sure that the reimbursement for those services continues past this public health emergency. So again, I think that's collaboration with Access for administrative policy change.
Yeah, that's really excellent. I totally agree. I see the medical integration really transiting into hub to spoke clinic where hygienists, particularly with the expanded function hygienists that can remove decay and place SDF and a smart fill. That's a great model for some of our rural areas and smaller clinics. So when we talk about advocacy, we're often getting into the things that we've talked about. Hey, we need this in order to, that really doesn't sell. What's the message for advocacy that really tells the story that can create the change?
I mean, for me, as an educator, I think that the message for advocacy is starting it on day one, that the healthcare provider is there, the student is there because of the fact that they want to make a difference. They want to help patients. And in order to help patients, they need to have oral health as part of the solution. And that is important for every patient, not just a select group of patients. So I think starting the conversation early and often and weaving this conversation into every aspect of health education, not just in one course, not just in one condition, but to allow them to recognize that they are interwoven in every single aspect, no matter what we're teaching our students. And so what my hope is that if we start it early and often, that those advocacy changes will make a difference.
It seems like, a lot of times change requires showing that the money's there. So that's probably one of the biggest things. If there's ever any way to show legislators the financial benefits of doing prevention. I know those studies are really hard and costly to do, and there probably haven't been a lot of them, but I think there are some out there just showing the financial benefit to the state budgets when we actually spend money on prevention instead of fixing things later. And just thinking about, well, I just wanted to mention two other things. Staffing is a really big deal. And so, Evie, I was thinking about the work that you do. Like, there's such a shortage of hygienists right now, sometimes dental assistants, depending where you are. So maybe something we don't always think about in the advocacy efforts is educating the people that we need to serve these populations is really important. I would say that.
Yeah. One of the things I like to fall back to is what it looks like if you can have a pretty young child. First tooth has appeared. You've got the parents there. There's maybe other siblings there. The parents are never more interested in the health of their child than that moment. And delivering the right care message improves the health of the parents, improves the health of the siblings, and improves the health of the target child. And I really think that kind of messaging is key to share. As we look at the numbers that we've seen in our screenings, 45% of kids don't have a dental home, and 25% have gross decay. You can add another 15 to 20% if you were taking radiographs. Those are the things that I think are really big messages. And, we have hopes for, better ears with different legislatures. But the truth is, when we message very clearly about what that actually means for the health of that child at 10 years, 15 years, and 25 years, when they're the adult that either is going to have a healthy mouth or another train wreck, everyone hears that. Everyone can hear that and see the importance of that. I think that's probably all of our time. Really appreciate the panel. I know that everyone on here is really engaged about these subjects, and just look forward to working with everyone and making the future that we're all dreaming of. Thanks so much.
Thank you all so very much. I'll echo Dr. Wilcox's appreciation. I took away a few kind of key themes from your conversation. One is definitely that leadership is absolutely critical. We need to continue to be working with access, with health plans, with our medical and dental leadership in our various settings in order to make this happen. And that there are lots of models, but all of the models really show definite success, but we're challenged with providing the right data to absolutely demonstrate that. And we know prevention data, as Cherith said, is really difficult, but I think we need to keep looking at those outcomes, and it's all kind of getting back to education. Education, as we've heard, that interprofessional education of medical providers is critical. We need to start them young, train them properly, because they are very interested in making sure that they do the best job in their medical careers possible, and that we need to keep working together. So those were a few of the takeaways. We've got to keep collecting the data, and we're going to hear more about workforce later, but I'm going to turn it over now to Tammy Baca and Brianna Miller to talk about the coalition. Thank you.